Joel, and thanks for the invitation to speak with you today. I'd like to begin with two disclosures. The first is listening to all the great sessions earlier today. I completely threw out everything I was going to present. So what you're going to get is going to be a little bit extemporary, but I hope it fits the flow. And the second is to confess that I've been leading a bit of a double life professionally. I've been in a rural practice for 30 plus years. Have had over 100,000 patient visits, delivered over 1,000 babies, but at the same time I've been a department chair in the 10th largest medical group in the United States. The other part of my life has been really as, for lack of a better term, a medical politician, leading both national and global physician associations, and in that capacity I've had the chance to meet with a number of heads of state, prime ministers, health ministers, and sort of think about healthcare at a very high altitude. But I've also made it a point to sit in on individual patient consultations, which I've done more than 5,000 times in more than 50 countries. And I share that with you because it will, I think, explain some of the biases I bring to this. I like the way that Bob Berenson sort of talked about the myths that he saw in measurement and in some of the system changes that are going on. So I decided to kind of structure what I'm going to say around that. And I think, and I hope what our panel has to offer you is that when you think about people in special circumstances or populations that are in special circumstances that might be marginalized economically, in many ways it allows us, I think, to see things with a clarity that gets lost among the well-fed, well-housed, well-closed populations. But you can't take that too far because those folks live among us too, and they're using the same social media and buying online at Amazon and all the rest. And so with that as sort of my disclosure of my biases, the first thing I would say is that one of the myths is that healthcare is about diseases. It's not about diseases. It's about people who sometimes have disease. And I think one of the mistakes we make when we talk about bending the cost curve and having the 5% that represent 50% of resource use, somehow shifting that curve, what we don't understand completely is that 5% is changing all the time. You go on and off that list of being among the 5%. I have patients that graduate from hospice and go back on again and graduate again. But I think the other thing that's important to remember in this is that, and this is where I think we've really lost our way as a healthcare system in the United States, especially as I travel the world, is that we have this idea that knowing the disease is more important than knowing the person. And that's just not true. I'll trump your knowledge of disease with my knowledge of the person every day of the week. Because you may have the greatest treatment in the world, and if they don't trust you, they ain't going to see you. Second myth is that patients are somehow passive passengers in this healthcare ship. And that's not been my experience. Patients have their own strong views and values. You know, I remember one lady who was a very heavy smoker. She was first time in my practice, came in for kind of an introductory visit. She looked like somebody that would have crawled out of the grave for a cigarette. And I was trying to figure out how to very politely raise the question of, you know, how much do you smoke and are you willing to quit? Because she was one of those kind of people where if you said to her, have a nice day, she'd say, no thanks, I have other plans. And so a key part of what you do in everyday practice is use skills like motivational interviewing, but as importantly, your knowledge of the person, your knowledge of the family, the community context. Those are key. The corollary to all this from the professional side is that we think that systems, organizations, and teams deliver care. They don't. It's people within those systems, organizations, and teams that deliver care, and that's an important distinction at several levels. One is that teams take a hell of a lot of work and time and energy, and sometimes it's well spent time and energy, and sometimes it's not. Teams take on a life of their own. And from the patient's point of view, how many people do you really want on your care team? How many do you want? How many do you want to know about your hepatitis C status, or even your hemorrhoids, right? It becomes unmanageable from the patient's point of view when we know that the third leading cause of death in this country is medical error, and that more than half of those errors are communication problems. You aren't going to prove that by adding more people to the care process. Even the military figured this out. That's why they had ads calling themselves an army of one. It's training very highly skilled soldiers to do a range of things, because having a bunch of subspecialists isn't the way to build a system. The fourth myth, which I got to pull up my glasses for because I wrote it too small, is that our science is sufficient to direct, not just guide or advise, to direct the care of individual patients. So as I went from a degree in philosophy to a law degree to a medical degree, I thought I was climbing this evidentiary ladder toward greater precision, accuracy, and objectivity, and it was just the opposite. I've spent most of my academic work in the area of quality improvement, guidelines. I've served on more than 36 national, international guidelines, and as a family doc, that's been really cool. Because I've been sitting at the table with the world expert, and you pick the disease, and I've probably been there. Diabetes, prostate disease, on and on and on, cancer. And you know what I found out in all those many hundreds of hours and thousands of articles? Is the emperors and empresses are wearing very little clothing. The technical term I would use is that much of our science sucks. And the reason it sucks is a whole conference into itself. We could go into that, but it has to do with how we measure things. I mean, who died and made that statistician God that says that 2 standard deviations is what we should allow for in terms of chance? Engineers demand 6 sigma. We're happy with 2 because we just take care of people, right? So it's a huge problem for us, and I can accept that. I can accept that our science is really incomplete and often irrelevant, frankly, in the care of the individual patient. What I won't accept is the arrogance of thinking that you can then universalize that to every single person before us. If you're prepared to go apologize to them when that bad thing happens because I followed your stupid-ass guideline, then I got no problems with you promulgating that guideline. I have yet to have a guideline writer take me up on that offer. Glasses again. And this has led to some movements that I don't know if many of you are aware of, but it is, to me, it looks like this wave that's about to become a tsunami. And it goes by various names among the professionals. It's called overdiagnosis, over-medicalization. You have pre-hypertension, you have pre-diabetes. I like to describe life as a pre-mortal condition. I mean, none of us gets out of here alive. And this can take a really ugly turn. For example, it can be something as drastic as autologous bone marrow transplant following high-dose chemotherapy for women with metastatic breast cancer. That went from being a research idea to a practice standard to legislated mandated benefit. And it doesn't work. It was killing more women than it was saving. And that's what happens when you have a combination of desperation for some answer, don't just stand there, do something, right? Well, sometimes just standing there is a better thing. In the world in which I live, which is actually where most healthcare happens, 3 out of 4 complaints are self-limited. My job is to not screw that up and actually do something to somebody. And how do I keep them from the unnecessary antibiotic when they have the upper respiratory? It's by leveraging the trust that I've developed with them and taking the time to talk them through their thought process, my thought process. Do I win every one of those conversations? Absolutely not. But I don't do half bad because I think I do take the time to have those conversations. As you think about this for the in the trenches clinicians, and for the patients it's even worse, it really is sort of a cacophony of noise out there. So I've been through 4 cycles of estrogen good, estrogen bad, estrogen good, estrogen bad. JNC 6 said keep your blood pressure below 140 over 90. JNC 7 said 130 over 80. JNC 8 we're still fighting over, and who knows what the next one's going to be after the ACP release from a couple of weeks ago. Who knows, right? That's the dilemma. The science sucks. And so we got to be very careful when we talk about standardization and what that means to the individual patient. So I wanted to finish with a brief anecdote or two to kind of drive this point home, that we take care of people one at a time. We don't take care of populations. You take care of people one at a time. And the first goes back about 5 years. These are both true stories. The first goes back about 5 years. And I go into an exam room, and it's a woman I've known a long time, and she's a really sharp journalist. She's a stringer, an independent journalist. And what she's been able to do for me at times when I couldn't find the answer to some research question I had and my medical librarian couldn't, I'd go to her and she'd somehow always get the answer. So I go into the room, and she won't even look at me, and I'm thinking, what's going on here? We've always had this great relationship. And looking up at the ceiling, her lower lip quivering, her eyes welling with tears, she said, why did you have that woman call me last week? I said, what woman? What are you talking about? Well, a nurse called last week, and she said she was calling on your behalf, and you wanted me to have a colonoscopy. I said, I didn't ask anybody to call you about a colonoscopy. I found out later that the higher-ups in our group had decided we were going to do central outreach without, of course, letting the primary docs know. Big mistake. I found that out later and apologized to her, but I didn't know that at the time. I said, I'm sorry, I don't know what happened. But she went on to say, well, don't you remember? Last year when I came in for my checkup, I told you my twin brother in another state had just died after a perforation from a colonoscopy, and I never wanted one. I didn't want to talk about it until I was ready. I said, yeah, I remember. And I turned the screen toward her. We use Epic, and on the left side I have the problem list. And under health maintenance it says, do not discuss colonoscopy unless she brings it up. So that kind of quiets her down. She's now looking at the right side of the screen, and there we have the best practice advisory in big orange box. There's the stuff that the group says you should be doing. At the top of her list it said colonoscopy, optical or virtual. And she says, why does that say colonoscopy, optical or virtual? I said, what do you mean? She said, well, shouldn't it say colorectal cancer screening? I said, well, yeah, you're probably right. She said, last year we talked this through and we went through the 5 choices with the U.S. Preventive Services Task Force. I said, yeah, that's right. She said, could it just say colonoscopy, optical or virtual, because you guys just built a $22 million digestive health center on University Avenue? I said, ooh, that's a really good question. And then she says, and why does it say virtual colonoscopy at all? Isn't that still viewed as experimental? And at the time it was. Still is, but USPS staff sort of caved on that one. And I said, well, yeah, but what do you mean? She said, could it have anything to do with the fact you got 2 leading researchers on virtual colonoscopy here at the university? I said, ooh, that's a really good question. And I left that encounter feeling slimy. I felt like a pimp, a tout, and I didn't like it. And I worked my way up the chain of command as high as I could get, and I told this story, and I said to the person, you know, I suspect why this woman came in so hot and bothered wasn't just the phone call, which was a bit upsetting to her, but 2 weeks earlier in our small town where I practice, we had a 37-year-old man die of a colonoscopy. Now, the fact that it was being done for diagnostic, not screening purposes, and the fact that it was an anesthetic catastrophe and not the scope itself was irrelevant to the community. All they knew was that TJ, father of 2, 37-year-old volunteer firefighter, went in for a simple procedure and came out dead, right? And it was in that context. Now, I don't blame the nurse that called from 100 miles away doing central outreach. I don't even necessarily blame sort of the organization for saying we want to do central outreach, but what I do blame us for is not taking the time to more clearly identify the patient's goals and then using practice redesign to accomplish that. Because most of what drives this, when we talk about whose values are we trying to address here, is it isn't the individual patient. It's the system, it's the payers, it's folks looking to get out of spending as much money they have, or people that have some academic sense of what good care is. And so when you talk about the problem with pay performance, what are you paying for? That's the question. I can see somebody score a touchdown, and I think that's valuable. What we do in healthcare is much more obscure because the science sucks. So I've given you a bad example. I'm going to give you a good example, though, that just happened yesterday before I got on the planes. My 12th patient of the morning. It's a newborn. He's actually about 4 months old. And those are always fun visits, right? They're getting smiley, they're interacting. But it's the maternal grandmother that brought in the baby. And as we're talking about the baby's doing fine. But the maternal grandmother's really upset about something, and so I say to her, what's going on? What are you upset about? Well, I'm worried about my daughter. And what's going on with her? Well, I think she's depressed. Okay, I just saw her 2 months ago for postpartum, but she was fine then. Please have her come on in or give me a call or send me an electronic message. And I said, why do you think she's depressed? Well, her husband started drinking again. Well, he's been my patient for 30 years. I said, I'm going to talk to him too. So as this thing plays out, I said, I'm going to have to finish now. I got to go catch a plane to O'Hare and then to Washington. My system's set up now that I have an embedded primary care mental health professional. I was able to get the young mom hooked up with her just with a phone call to my nurse. And since nobody else can confront this guy about his alcoholism but me, frankly, because I've done it twice before, I was able to send him in Epic, it's called a MyChart message electronically in a very kind of bland way. Hey, Jim, how you been doing? Yeah, it looks like that cholesterol we did last month, blah, blah, blah. I want to see it. And so we've got an appointment set up for next week to do another intervention. Here's the challenge in our current health system. How do you measure that? Evaluate the value of it? Because I think it's incredibly valuable. Secondly, how do you compensate for it? And I'm not sure you can. So the very final thing that I'll say about all this in terms of performance and measuring performance is we also have the arrogance as a country to think we're the only ones thinking about these issues. The largest public health experiment in the history of humankind has actually been described as what the England and the UK went through with the Quality Outcomes Framework, where British GPs were being paid to hit targets, 165 targets. And I got very involved with that process early on, back in 2003, 2004. And I met with a young Deputy Minister of Health. She was an economist, very smart lady. She did her presentation for us before they were going to roll it out. And she said, "What do you think, doctor?" And I said, "Well, Madam Minister, you're going to be changing physician behavior, I can promise you that, because you put so much money into it. It'll be up to a quarter of their total compensation. But I said, you better be careful what you measure, because that's what's going to get valued." And I said, the second mistake you've made is that you've underestimated how much you're going to pay. She said 75%. I guessed 85%. It ended up being 91%. And she sent me this cute little email a couple years later. "How did you know?" I said, "Well, Madam Minister, doctors are genetically bred and sociologically trained to ace the curve. We're going to figure out how to hit the target if you put that target out there. You just better damn well make sure it's a target that patients value."